Yes, yes. Shall I invite Dr. Ghoshal?
Yes, please.
So it's my great pleasure to invite one of my senior and my teacher also, Professor Uday Ghoshal. He is currently the head of Department of Gastroenterology at Sanjay Gandhi PGI, my alma mater, Lucknow. He is a world-renowned person in the field of luminal gastroenterology. He is a fellow of Rome and is a part of the team who gives the Rome classification for functional bowel disorders. So today he'll be speaking on bile acid diarrhea, the role of bile acid in the diarrhea due to IBSD and others. So can I invite Dr. Ghoshal to start his talk, please?
Yeah, I'll do that. I'm trying
to share your screen.
Yes.
Yes, please go ahead.
Can you see my slides?
Yes, Dr. Ghoshal, we can see your slides very well. Please start.
Yeah. Thank you. It is nice talking to you on this important subject, that is bile acid malabsorption in functional diarrhea and diarrhea predominant irritable bowel syndrome. Now we all know that the disorders such as functional gastrointestinal disorders have been renamed. Now we do not call these as functional gastrointestinal disorder. We call these as disorders of gut-brain interaction. So abbreviation is DGBI, disorders of gut-brain interaction. I'll tell you why we changed the name. But before that, this is the biggest epidemiological studies on GI disease in the world. We have earlier known about such epidemiological studies, big one in cardiac diseases, but this is the biggest epidemiological studies on GI diseases done all over the world. This included more than 70,000 people in 33 countries of the world. And what we found is that DGBIs are not uncommon. About 40% of the world population suffer from one or more DGBIs. Fortunately, in India, frequency was lesser than that in the West. And if you look at the frequency of IBS, IBS was rather uncommon. Less than 4% of people in the world had irritable bowel syndrome. Now, IBS truly is multifactorial in pathogenesis. If you just look at this slide, it tells you what are the pathogenetic mechanisms of IBS. These include visceral hypersensitivity, altered motility of the gut, low-grade inflammation and permeability alteration of the gut, dietary intolerance, pathogenic infection, altered gut microbiota, local neurohormonal dysregulation, genetic factor, psychological factor, and stress. All these together result in a dysregulated gut-brain interaction. Now, what is the common view of IBS in the past? IBS was called in the past as functional. When we said functional, we did not really mean that these are psychogenic. We meant these are alteration in the physiology and not alteration in the anatomy. But people and physicians started interpreting this as idiopathic or cryptogenic. They thought patients were neurotic, they were apprehensive, and they were otherwise healthy individual with an imaginary illness. This really did disservice to this patient, because the patient came with their suffering and the doctors thought these are all imaginary, these are all because of apprehension, and therefore they were not given due attention. Now we have changed the concept of IBS. IBS basically means what is the immune response of the host to the luminal factor, including the dietary factor, and how GI events such as altered inflammation or increased inflammation is sensed by the organ, what microbiota we have, what food we ate, and how our brain start perceiving the problems that are happening in the gut. So that's why what we did in Rome is we changed IBS from functional GI disorder to disorder of gut-brain interaction. So look here, in the current terminology, we don't say brain-gut disorder, we say gut-brain disorder. Why we say that? Because we know the gut is the primary place for the pathology, brain is secondary. Earlier people were thinking brain is the primary and gut is the secondary. So if the gut has the major problem, what are the problem in the gut? The problem of the gut are multiple, such as, let us say, how much inflammation occur in the gut, maybe because of altered cytokine response. Somebody can have excess of pro-inflammatory cytokine and less of anti-inflammatory cytokine. How much sensation does the gut have of that individual? So all these together, this is a very complex slide, but I do not want to go through everything of this slide. But all these together are now sensed in the brain, and that lead to symptoms of FGID or DGBI, including IBS. Now, what my job now is to say there is a misconception in the diagnosis of IBS. Many prescriptions that I see in the day-to-day in the OPD, what happens is the fellow doesn't have IBS, but he has been labeled as IBS. That's why I'm going to talk about definitions. So if you look at diarrhea, chronic diarrhea could be organic or chronic diarrhea could be functional. Now, when somebody has functional diarrhea, it could be, truly speaking, functional diarrhea only or IBSD. So what is IBSD? IBSD means diarrhea predominant IBS. Diarrhea predominant IBS means the fellow not only has diarrhea of functional nature or non-organic nature, because as I told you that the functional is really a wrong term, it is non-organic. But when I am saying non-organic, it does not truly means non-organic. It means this may be microorganic. If we find organic abnormality at the molecular level, still you can call this as IBS. So when somebody has pain plus non-organic diarrhea, this is IBSD. On the other hand, somebody has non-organic diarrhea with no abdominal pain, this is functional diarrhea. So bile acid malabsorption can cause both functional diarrhea or IBSD. The pain means IBSD, diarrhea with pain, and only diarrhea, no pain means functional diarrhea. And also diarrhea must not be diagnosed by stool frequency alone, but you look at Bristol stool form scale. Now this is the Bristol stool form scale shown here in the chart, and if somebody is passing predominantly type 6 or 7 stool, and predominant means more than 25%. So if over 1 to 2 weeks bowel diarrhea, you find somebody is passing more than 25% stool, which are type 6 or 7, and less than 25% are constipation stool, such as type 1 and type 2, and even we call this type 3, then this is diarrhea. Now this diarrhea, if it is painful, then this is IBSD. Non-painful means functional diarrhea. To recapitulate this again, look at this man. He has predominant problem in the bowel. So that means he is passing loose stool, but he does not have pain. So this will be called as functional diarrhea. And look at this lady. She has a bowel problem such as diarrhea, but also has abdominal pain. And this will be called as IBSD. And in fact, according to Rome 3, we said pain should be there at least 3 days a month. But according to Rome 4, we said that pain must be there at least 1 day a week. Now, we explained to you what is functional diarrhea and IBSD, and what are the causes of IBSD or functional diarrhea. It could be lactose or fructose malabsorption, bile acid malabsorption, non-celiac wilt intolerance, and FODMAP intolerance. FODMAP is an acronym, stand for fermentable oligo di monosaccharide and polyol. Fermentable oligo di monosaccharide and polyol. Small intestinal bacterial overgrowth and gut microbiota or fecal microbiota dysbiosis, immune activation, and post-infection. So these are all the causes of diarrhea predominant IBS. But obviously in today's presentation, I am not going to talk about all these, but what I am going to talk about is bile acid malabsorption. Now, if you look at the bile acid metabolism, we all know that the bile acids are secreted or excreted from the liver. They come through the bile duct, and then in the bowel, they help in the digestion of fat and many other functions. Now, what happens is normally 5% or less than 5% of the bile acid go into the colon, and 95% of the bile acid is reabsorbed in the terminal ileum by what is called as intestinal bile acid transporter or IBAT. Now what happens is, therefore, this 95% goes back to the liver and it is excreted again, and this is called enterohepatic recirculation of bile acid. But the 5% of the bile acid which reaches the colon, by bacterial metabolism, they are converted to secondary bile acid. So secondary bile acid now has several functions. For example, bile acid increases gut motility. Bile acid increases secretion from the gut. So therefore, if it increases motility, if it increases secretion, you know what will happen because of bile acid? It will result into diarrhea. So diarrhea occurs if there is an excess of bile acid. On the other hand, if somebody has less bile acid, that means more bile acid has gone into enterohepatic recirculation, therefore less is available in the colon, then what will happen is the fellow will have constipation. So less bile acid in the colon is constipation, more bile acid in the colon is diarrhea. Obviously, we are going to talk about diarrhea today and not the constipation. But if you go further into it, the bile acid, when it comes into the lumen in the ileum, it stimulates some gene in the ileal epithelial cell. So it induces some gene in the ileal epithelial cell. These are called farnesoid X receptor or effexor. So bile acid themselves actually stimulate or causes more expression of a gene which is called effexor or farnesoid X receptor. Now farnesoid X receptor results into liberation of a protein called FGF19. Okay, FGF19, and this FGF19 give a negative feedback to the liver to produce less bile acid from cholesterol and also to secrete less bile acid. So if somebody has more effexor and more FGF19, he will have less bile acid in the colon and therefore he will have constipation. On the other hand, if somebody has less effexor and less FGF19, so he will have more bile acid in the colon and will have diarrhea. Similarly, if we can induce effexor, now if in a diarrhea predominant patient, if we can induce effexor, then the diarrhea can get control because there will be a reduction in the amount of bile acid in the colon. Look at the bile acid malabsorption studies in IBS. So I took a meta-analysis published in 2015 in Elementary Pharmacology and Therapeutics. And what this author did is, of all the available studies Actually, they selected 6 studies which are of reasonable quality, and they found that yes, most of the studies showed that there is a higher frequency of the bile acid malabsorption among patients with irritable bowel syndrome of diarrhea predominant type. Now, also what author did is took the two prospective studies separately, and did the meta-analysis and made a forest plot with these two prospective studies. And what they found is actually even the prospective studies also showed that there is a higher proportion of bile acid malabsorption to the tune of about 25% among patients with diarrhea predominant IBS. Now we all know in the meta-analysis, these actually represent effect size of that particular study. So higher is the size of this block, actually it means larger is the sample size. Now this is the effect size, and you can here see effect size is around 3.5 for this study and around 1.8 for these studies. And this is 95% confidence interval, and narrower the 95% confidence interval, better is the study. So this rhomboid is actually the pooled proportion, and these are proportion or effect size of the individual studies. So from this meta-analysis published in 2005, you can see that whatever data is available in literature, most studies showed that there is a higher frequency of bile acid malabsorption in IBS diarrhea. And this is the quality assessment of these 6 studies. So the author found these are of reasonable quality. That's why they included these studies in the meta-analysis. You will say, how is the bile acid malabsorption diagnosed? Typically, it is diagnosed by a test called 75 selenium homocholic acid Dorine test. In short, it is called SC-CAT test. So 75 selenium homocholic acid Dorine test. And if somebody has more retention, obviously it is normal, and if somebody has less retention, it is abnormal. But let me tell you, this test is not available. In fact, in a review published in 2018, they showed that only 12 European countries and Canada, 12 European countries and Canada had this test available. Even the America, many center did not have this test. And to the best of my knowledge, no center in India has the facility for this test. So therefore, we can say this bile acid malabsorption test is not available. Now, the other alternative is fecal bile acid estimation. And in fact, we do fecal bile acid estimation in our lab. And whatever data we have little bit is based on the fecal bile acid estimation and not by the SC-CAT test. Now, also, I told you that bile acid stimulate colonic motility or gut motility. Bile acid also increases secretion. What is the proof that bile acid stimulate colonic motility? Here is a study where the author looked at fecal bile acid excretion on one side and colonic transit at 48 hours on the other side, and they found there is a relationship. More fecal bile acid means faster colon transit time. Now, can we treat bile acid malabsorption or bile acid diarrhea by any drug? Yes, we have cholestyramine available in the market, and in fact, in many patients of functional diarrhea and IBSD, I use cholestyramine. In fact, I start them on ramosetron because ramosetron or ondansetron we know is a serotonin blocker, and we all know diarrhea IBS patient has excess serotonin in their gut mucosa. Why I give this drug first is because this is very patient are more compliant. It is a small tablet once daily, whereas cholestyramine is associated with less compliance because you have to take half sachet twice daily. It is bad in taste. It has drug interaction, so patient don't like it. So my first line is a serotonin blocker, such as ramosetron or ondansetron. The second line is drug is bile acid binding agent. One more thing, if a patient comes to you with diarrhea looking like functional diarrhea or IBSD, and the patient says that he underwent cholecystectomy, even though you do not have available test for fecal bile acid estimation in your lab, or you don't have a CCAT test in your lab or CCAT test in your lab, now you try cholestyramine in your patient, because this is a meta-analysis which showed that many a time patient who had surgery of gallbladder or cholecystectomy, now they have diarrhea, there is a higher frequency of bile acid malabsorption and they respond more to cholestyramine. So this is a meta-analysis. This is another drug which works to reduce fecal bile acid. This is colesevelam. So colesevelam is not widely available in the Indian market, but therefore I sparingly used colesevelam. So this is a study from Michael Camilleri, Mayo Clinic, Rochester, who showed colesevelam works in patient with bile acid diarrhea. This is a next study again done by the same author, published more recently, which again showed that colesevelam works in bile acid malabsorption or bile acid diarrhea. So if you are not using cholestyramine, you can use colesevelam. Colesevelam is available in the West as 60 25 milligram tablet, and you typically give 3 tablets twice daily. But let me tell you, the dose is not so fixed. Like cholestyramine, I don't really give a large dose. I actually titrate the dose to get the desired effect, because lesser dose would be better and associated with more compliance. And in fact, if you give a large dose at the beginning itself, patient can develop severe constipation. Now we all know obeticholic acid. Obeticholic acid is an FXR agonist. So what it does is it actually is an agonist of FXR in the ileal epithelial cell. So therefore there will be an overexpression of FXR gene that will be associated with more production of FGF19, and the FGF19 will inhibit bile acid excretion from the liver and therefore works in the bile acid diarrhea. And this is a study published in Elementary Pharmacology and Therapeutic, which showed that if you use obeticholic acid, it reduces the fecal bile acid frequency of stool and form of the stool. So therefore, let me conclude that IBS is a multifactorial in pathogenesis. IBS diarrhea has different pathogenetic mechanism than IBS constipation. Functional diarrhea is similar to IBS-C, has similar pathogenetic mechanism compared to functional constipation. And I covered today bile acid mediated mechanism. Bile acid malabsorption is common among patients with IBSD and functional diarrhea. Tests for bile acid malabsorption are not widely available, even in the Western countries. So don't feel that your country doesn't have enough facility, because even in the America, it is hardly available. Drugs reducing fecal bile acid are useful in treatment of patients with IBSD and functional diarrhea, and I often use them even empirically. Obeticholic acid has also been found useful in patients with bile acid malabsorption. Thank you so much.
Thank you very much, Dr. Ghoshal. You have made this complex subject so simple. It looked like it's very easy to learn from you. I think you are a good teacher as usual. So tell me, suppose a person with functional diarrhea comes in our OPD. So what are the symptoms when you suspect them he could be having some kind of bile acid malabsorption? Apart from the history of cholecystectomy, leave aside this other thing, other than this.
There is hardly any other good way to suspect that whether he has or he doesn't have. So what happens is clinically there are not many options to say that he has bile acid malabsorption or not. What I do is I suspect diarrhea and IBSD, I suspect that he could be having bile acid malabsorption. And what I do is typically I give them, as I told you, ondansetron or Ramosetron first. And if it doesn't work, the second visit, if he says, no, I did not improve, I give cholestyramine half sachet in the morning and half sachet in the evening. Remember one thing, cholestyramine binds all the drug that you give along with it. So always advise your patient, take at least 1 to 2 hour gap between cholestyramine and any other drug that you may be using. And then if he responds, I know that he may be having bile acid diarrhea. There is no other way. Now, yes, recently we have started doing fecal bile acid in our lab, but it is very cumbersome. You have to collect stool for 3 days. So then you have to mix the whole of the stool of a particular day, take a sample and estimate the fecal bile acid in that. Very cumbersome for the patient as well as the laboratory people. So therefore, it is more of a sort of investigational tool rather than a very great clinical tool, because it is not easy to do. So clinical medicine is take look at the patient. If there is a stool type 5 or 6 or 7, if this is functional or non-organic, I see the effect.
Have you ever used obeticholic acid for this indication?
Yes,
Yes,
can
yes,
you
now it
repeat
is
the
audible.
question?
Have you ever used obeticholic acid for this indication?
Yeah, but obeticholic acid came recently. No, I have not yet used obeticholic acid for my functional diarrhea or IBS-D patient. But currently, obeticholic acid is not approved for that indication in it. So therefore, you have to apply. And I know.
Yes, sir. Dr. Vinod, any other questions in the chat box?
Off level, sorry.
अच्छा वो
So
I think it has been so nicely described. I think you were correct. A wonderful teacher. We have heard him speaking so often, and he explains it so nicely that everything is quite clear. I have Dr. Sukhdev Chaudhary. If you have any questions, Dr. Sukhdev Chaudhary, do we have any questions?
I think you are muted, Sukhdev. Sukhdev, I think unmute yourself and then speak.
Unmute yourself, Dr. Sukhdev. Can you unmute yourself and ask the question?
Hello,
Yes.
sir. Question is role of fecal microbiota in obesity.
So are you
Okay.
to me?
You can answer, any of you, Dr. Ghoshal or Dr. Ghoshal, any of you can answer.
Yeah, so are you asking me? Okay. Let me tell you that
Yes, sir.
fecal microbiota transplant, apart from C. diff infection, recurrent C. diff infection, has not been approved for most other indications. So therefore, you can't use it as yes. It has already started. We are doing it regularly. So therefore, apart from recurrent C. diff. In IBS, FDA has a practical requirement that if you are doing FMT for IBS, you have to do it as a trial. If not compliant, you have ethics clearance. Without that, Ghoshal said 1 week ago, a paper has come in Nature. It is a good paper. It suggests a reasonable result. But I tell you, in practical terms, it will not be a great option, because those who are obese, somebody having BMI of 35, his BMI has happened to many years, decades. Don't think by trying to change his microbiota by FMT will really give a great result, because in adulthood, microbiota cannot be changed. Only temporarily it can be changed. It cannot be changed. So therefore, I believe these are good for research studies. Yes, microbiota dysbiosis is known to be associated with obesity. It has been proved by good studies, But these are pathogenetic mechanisms. But pathogenetic mechanism will not always translate to therapy. For example, you have a liver cancer patient due to hepatitis B. Treating hepatitis B will not have liver cancer. You have a gastric cancer patient due to Helicobacter pylori. Now, after gastric cancer has developed, treating Helicobacter pylori is not going to eradicate gastric cancer. So the same is the story for obesity and microbiota dysbiosis.
Thank you so much, sir. Thank you.
Yes. Yes, I think there are no other questions, and I thank both the great speakers, Dr. Ghoshal, Dr. Uday Ghoshal, for their great disposition of this subject. And I hand over the mic to the organizer on behalf of Dr. Vinawat and Knowledge Genie team. Yes. I thank both of
very
them.
much, sir.
Thank you very much. Yes.
Yeah.
Yes.
Thank you, sir. Thank you very much. Thank you, Dr. Ghoshal. Thank you, Dr. Kaushal Vyas. And my special thanks to Dr. Sunil Dadij, who has really convened this session so wonderfully. And we have been able to hear so wonderful lectures right in the morning. Thank you very much, sir. Thank you for the time given to us. Thank you very much, sir.
Yes. Thanks. Thanks, everyone. Yes.